My experience in arthroplasty goes back about 7 or 8 years. I started doing the FDA clinical trial for the ProDisc at that point in time, and then have done quite a few cases since then. These are some of the articles that I've recently published in Spine and other journals. Some of the lecture stuff that I'm going to talk about today can be found in a book that we recently published for the SAS this past month. These are the basic concepts that I'm going to talk about today. What is evidence-based medicine? What do outcomes mean for you as physicians? Update on the IDE studies, and then lastly summarize some of these concepts with some real-world examples. So evidence-based medicine. If you ever want to read 2 pages of a very cogently presented presentation on what is evidence-based medicine, read these 2 pages. You can get these anywhere on the internet. Sackett. This is probably the best definition of evidence-based medicine you can find. Practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. It is not the ivory tower blinded randomized clinical trials that we all think of. It is a combination of what you experience as clinical physicians as well as what you read and are presented with in the literature. Obviously, if you're going to jump out of a plane, you don't need a randomized clinical trial to tell you that it's safer to wear a parachute. So not every question in the medical world needs a randomized clinical trial. The real most important question for you when you pick up a journal or when you look at any kind of literature or you decide to write or do any kind of research is asking the precise right question. So here's an example. Is surgery for low back pain effective? Would that be better or worse than when should surgery be used for patients with low back pain and degenerative disc disease? Or even better, is lumbar disc replacement more effective than intensive rehabilitation in patients with chronic low back pain and DDD as measured by improvement in certain outcomes? Okay, so it's really the question that is the most important process in all of this evidence-based medicine review. Some questions cannot be answered by evidence-based medicine, and some of them are mainly focused on opinion and consensus, such as PSA levels. The next biggest item you want to check off on your list when you're reading a journal or on arthroplasty or any other medical review is what is the control group. I don't know if many of you have heard of this term, but regression to the mean. Basically, it's a fancy way of saying, well, a disease process can oscillate up and down. So low back pain, you could have a really bad day or you could have a really good day. And if you pick patients for a study on a really good day, your results will be a lot different than if you pick a group of patients on a bad day. So having a control group is critical. What are the different types of studies? Different studies such as comparative studies. This is not a randomized group of patients. It is looking at 2 different types of patient groups, but they are not randomized. Mostly these types of comparative studies will attempt to randomize patients either using alternating enrollment, birth dates, or social security numbers. A historical control study is a type of comparative study using patients from a previous time period to a more recent time period. Case control study. Okay, this is not a case study. This is a group of patients that you had in a study that may have had an inadvertent or a complication, and you look at those patients in a separate subgroup. Okay, so that's a case control study. It's really a study of rare events within a particular study that you're looking at. Okay, prospective randomized control study. This is the level 1 evidence, and randomized studies try and negate the selection bias that can occur in a cohort of patients. So if you look in this room right now, we have predominantly males, right? If you performed a study in this group, we'd have a selection bias, right? So the randomized control study tries to eliminate selection bias by looking at a whole pool of the population and averaging out any of the types of selection bias that may or may not occur. Other types of bias include attrition bias, in other words, no follow-up, investigator bias, investigator might have some conflict of interest or something, performance bias, and others. The next question you want to ask yourself when you're looking at a journal is, what were the outcome measurements, and were they measured adequately? Was a standard instrument used to measure the outcomes? Was there less than a 15% difference in the length of follow-ups between the two patient populations? Was there less than a 15% difference in the completion rates of the study groups? If these questions aren't answered in that particular study you're looking at, the study really is not adequately addressing the questions that it posed at the beginning. I'm sure you've seen this in one of the journals, either in the JBJS or Journal of Neurosurgery or Hand Society or whichever one you have. These are pretty much the levels of evidence that are looked at this juncture in time. Level 1 being the high-quality randomized clinical trials. Level 2 being the lesser quality randomized clinical trials with less than 80% follow-up. Prospective comparative studies. Level 3, case control studies, retrospective comparative studies, and systematic review of level 3 studies. And then 4 and 5 are case series and expert opinions. Just because level 1 has a 1 next to it and level 5 has a 5 next to it doesn't always mean that the level 1 studies are the studies that you have to go to as the Bible. A level 4 study can actually tell you more if it's done more appropriately as far as asking the correct question, having a more defined outcome analysis. So be very critical of what you read. Who cares? You know, everyone's in this room saying, boy, I didn't come here to learn about evidence-based medicine. It's not going to affect me. Well, I beg to differ. I think that, and I'll show you an example just shortly on how this is going to affect all of us. Patients care. I'm sure patients have come to you and said, how many of these types of procedures have you done? What are your outcomes? What are your complications? Hospitals are starting to become more critical of us now with these types of questions. And payers. Okay, this is a letter that I got. It's kind of blurry. It's dated March 13th, 2008. It's from the Peerless Insurance Company, which is a major coverer in my state. If you look at the question number 3, please provide a summary of your outcomes for cervical disc replacement. They wanted to know what the VAS score was, what the neck disability index score was, what were my complication rates. This is real world. This is happening right now. Okay? Outcomes allow us to assess things in a multiple different ways. They allow us to see what type of intervention we can expect, or results from an intervention we can get. They act as research tools. They allow us to understand the literature more clearly. Let's take an example. Prospective randomized clinical trial, the Bryan cervical disc replacement. This is an artificial disc for the cervical spine for patients with disc herniations. There's a prospective randomized level 1 cervical disc. They had 56 artificial discs and 58 control groups, which were fusion. Outcome measures were range of motion, neck disability index, visual analog scale, and the short form SF36 questionnaire. The results showed a neck disability index of Bryan at 1 year 10 and control 18. This was deemed statistically significant. The two means were statistically different. At 2 years, the same thing happened, even more so. How about arm pain? Well, when you put the disc replacement in a patient with arm pain, the Bryan disc had 12 at 1 year and 14 at 2 years. The control group, again, were statistically significant. Same thing for the neck pain. How about SF36? Even more so in this questionnaire, specific questionnaire. The Bryan disc performed better than the control group. At least it looks like so. So the conclusions about this paper would be that motion was retained, outcomes were significantly better, and the Bryan disc performs favorably relative to the control group, which was a fusion. We'll look at this a little bit later, just after we discuss a few more items. Outcomes really are focused on the patient's assessment of pain, function, quality of life, and satisfaction. That's how you really need to think about outcomes. That's going to be the important portion of an outcomes measurement for you. If you look at outcomes research, there are two types that can be evaluated, hard data and soft data. If you look at the soft data versus hard data, as far as reliability goes, both of them are reliable. Some people will say, oh, well, you fill out a form, patient has to sit there for 10 minutes, they get tired, they don't fill out the forms correctly. It's not true. If you look at the kappa values for soft data versus hard data, they're very similar. All outcomes may not be the same. In other words, if you have a fusion, that doesn't always mean a good outcome. Odom's criteria, this was one of the first papers published on outcomes criteria. It just had a 4-scale, 4-component evaluation. It's actually still used. VAS scale, visual analog scale, basically you ask the patient to take a pencil and draw a line. Where is your pain? 0 to 100, or 0 to 10, depending on what your ruler is measuring. Most questionnaires tend to be more specific, and they can be divided into the general health category or the disease-specific category. They all stem from the World Health definition, which divides health into 6 general levels and health-related quality of life categories and domains. These are the domains of the health-related quality of life World Health categories. SF36 you're very familiar with. Sickness impact profile and others exist. Of these, the SF36 is the most common. As it implies, there are 36 questions. Most recent revision was in 1996. These are the categories for the SF36. Basically, there's 8 health concepts broken up into physical and mental categories. Each question is ranked from 0 to 100, 100 being good, low numbers being bad. Data can be compared to normative data. Sometimes, again, these are general health specific questionnaires. If you look at the actual pain score, only 2 questions out of the 36 pertain to pain in the SF36. Other disease-specific questionnaires have been developed, and again, our example looked at neck disability index. There are 10 questions, each one scored from 0 to 5. You just add up the total from the 0 to 5 of the 10 questions, divide it by 50, multiply it by 100. This is an example of one of the questions in the neck disability index score. Again, 0 to 5, the patient just checks off a box. You take that number and add them all up for the 10 questions. It's really quick and easy. Same thing for the lumbar spine. Oswestry score is one of the most common, and the NAS lumbar spine questionnaire. There are others that I won't go into today, but it's important to recognize that for you, as orthopedic surgeons, there are these types of questionnaires for all of your practices. Hip, knee, shoulder, hand. These are things you should be incorporating in your practice. If you don't do anything else in your practice, take a piece of paper, draw a line from 0 to 100, photocopy it 100 times, and stick it in your new patient questionnaire when the new patient comes into your office. Have that patient say, this is where my pain is. And a year after, say, you do your knee replacement or shoulder replacement, have them draw another line. It takes them about 1 second to draw that line. But as I showed you in that letter from that insurance company, that will make or break your practice in the future. Very simple. Properties of outcome, validity, reliability, these are all important. Sensitivity and responsiveness. I won't go into the nitty-gritty of these things, but they all combine to produce an outcome, a good outcome that can be measured significantly. All right, this is a key slide. What difference is clinically significant, right? A new term, relatively new term, has been defined recently called the minimally important change. You take these outcome studies, these tools, right, the Oswestry, and you ask yourself, well, what change would I have to get from a patient after surgery such that I will have a significant change and impact in this patient's life? If you look at the VAS, that's defined as 15. So I have to improve that patient's life of pain by 15 millimeters. How about the neck disability? I've got to improve it by 10.5 percentage points. Roland Morris on Oswestry. And you can also put these into percentage changes, obviously, by dividing the total. If you take a patient and you have a high level of functioning and you use the wrong outcome score, you're not going to get the right answer. So be careful when you use the outcomes. So let's go back to our paper that we just looked at before, looking at the Bryant artificial disc. Again, we looked at this randomized clinical trial. There were outcome measures. They asked a very good question. They had very good outcome measurements. They used range of motion, neck disability, VAS, and SF36. So they used both hard and soft outcome measures. The NDI, if you look at the NDI improvement, again, say let's go to the 2 years. The Brian had an 11, the control had a 20. 10 and 18. The difference was 8 and 9 MIC. So in actuality, even though this paper showed statistical significance between these two groups, it was not clinically significant for the patients. So in actuality, this paper would not show clinical significance for a patient population. How about VAS? If you look at the VAS for neck and arm pain, again, we need a minimal improvement of 15. At 1 year and 2 years for both neck and arm, only at 2 years do we get improvement for the neck at 16. So again, even though there was statistical significance, this paper did not show that clinically there was a clinical significance. How about SF36? Same thing. Not really clear because there was no mental component here, but the physical component also was not significant. Okay, so what are some of the current IDE clinical trials? Now I'm going to kind of blend a little bit more of the real-world IDE clinical trials for some of the spine guys in the group. Review of terminology, IDE, investigational device exemption, 510K, pre-market notification. These are some of the terms you may hear being floating around, when you're talking about different types of clinical trials. The IDE process, which is the prospective randomized clinical trial process, has many advantages, but it also has many disadvantages as far as the cost and time that are incurred. The timeline can be variable depending on what you're trying to achieve. Studies can often be delayed. The evaluation process is very time-consuming. For example, the OP1 posterior lateral study that was performed finished enrollment in 2004. More studies by the FDA were requested, and as of 2008, they're still in a human device exemption trial or status. If you want to look up any kind of clinical trial data, you can go to clinicaltrials.gov. Everything is public, believe it or not. It just takes a little searching. This is one type of disc replacement that's being evaluated called the Discover disc replacement. This is another one called the Active C, which will start a clinical trial shortly. It's made by company Escalap. This is the timeline for the cervical arthroplasty that is out there right now. ProDisc C was approved. Prestige was approved. These are the other disc replacements that are out there right now under clinical trials. How about lumbar? This is the Escalap Active L disc replacement. This is the Flexicor. These are the timelines at the moment. The ProDisc, the Charité was the first one approved in 2004. ProDisc was approved in 2006. And this is the relative timeline for the other arthroplasty devices. Posterior motion sparing, these are pedicle screw-based devices. Some of them are undergoing a 510K pathway. They're trying to get approved as a result of their similarity to pedicle screw fixation posteriorly in the spine. Some of them are undergoing IDEs, such as the Dynasys and Stabilimax. This is the Stabilimax device, actually invented by Dr. Panjabi from Yale. And this is the timeline for these devices. Facet replacement is also being performed now under IDE clinical trials. This is the anatomic facet replacement system. Presently, it's under a pilot study, pivotal study to start shortly. And this is the timeline for the facet replacement devices that are out there. Interspinous spacers, such as the X-stop, which is used to treat spinal stenosis. It's comparing decompression. The Diam from Medtronic started 2008. The Wallace device had started a clinical trial, but then it stopped. I couldn't exactly tell why. The company wasn't open to discussion after I called them. The X-stop was approved in 2005, and this is the timeline for the other interspinous devices. Real quickly, I've got about how much time do I have left? 5 or 10 minutes. Okay, great. I'll just whip through another example of an IDE study that I was involved in. Multi-center clinical trial, 17 centers, 292 patients, 2-to-1 randomization. These are the demographics: males, mean age very similar between females and males. Intraoperatively, if you compare the protus to a fusion, statistically significant, less blood loss, surgery time, and hospital stay. Device safety, from a complication standpoint, blood loss, vessel damage, and nerve root injury was less, although not, and it was statistically significant in the neurological success category. Oswestry Disability Index, if you look at the follow-up study periods from pre-op to 2 years, and now actually we have 5-year data now, that was just presented here in Miami last week. This is the Oswestry improvement. These were statistically and clinically significant in patients. How about the VAS? The VAS was statistically significant at 6 weeks, but interestingly, pain scores were equal after that, and now we have 5-year data. And so the VAS was actually the same between fusion and disc replacement at 2 years, and now up to 5 years we have data on. Radiographic evaluation, obviously range of motion was much greater with the replacement group. The fusion status of these patients, none of the patients with the protus demonstrated autofusion. 97% of the control patients demonstrated radiographic fusion at 24 months. If you ask these patients, would you have surgery again, a preponderance of these patients said yes. VAS satisfaction at 24 months was higher for the protus patients than the fusion patients. So the overall success, what does that mean in an IDE study? These are the 10 primary endpoints that we submitted to the FDA. Each one of these questions had to be successful for that patient to be deemed a success. So if we were missing, say, one X-ray at one time point in that 2-year period, that patient would be deemed a failure, even though the rest of these questions were positive. If we were missing one X-ray or one SF-36 form, or even just a question in the SF-36 form, that particular patient was deemed a failure. These are the success rates. If you look at the protus versus the fusion patients, statistical significance was achieved, again, with the ODI and neurological. And the overall success rate comparing fusion to disc replacement, again, protus was statistically higher than the fusion. And again, you ask yourself, boy, 63.5%, that's terrible. Well, again, remember, if one of those 10 questions was not positive, patients were thrown out. So you have to remember that a lot of patients were eliminated from the study because of that. Midway through the study, the FDA asked us to use a 15-point improvement rather than percentage points, so we had to go back and do this again. And if we did it again, we were still statistically significant, and even more so. There are training cases. Those were the first 3 cases that were done. Again, showing an overall success rate that was at par or slightly better than the fusion patients. No major complications. If you look at other studies that had fewer endpoints, again, protus had 10, the Charité versus BAK had 4 outcome studies, and the LTK outcome measurements and the LTKs with fusion only had 5. So these are the results from that particular study that led to the eventual FDA approval. So as I stated at the beginning of my lecture, evidence-based medicine is not just randomized clinical trials. It's what you experience as a physician also, and that can play a major part in defining what really is evidence-based medicine. And here's a patient that I had, 49-year-old female. This is my last 2 slides. Former alcoholic, did not want to be on narcotics, single mom, 2 kids, worked as a consultant. This is her MRI, 3 levels of degeneration. This is her x-rays post-operatively. And if you can imagine, if you looked at these slides pre-operatively, if you were going to treat this, say, with a fusion, you'd have to fuse probably above the thoracolumbar area all the way down to the pelvis. But using this newer technology, we were able to achieve this outcome. And then about 5 months after, I saw her in Vancouver, Whistler. I was just skiing there with my kids, and someone bumps into the back of me, and this is her. So we don't know exactly where all these clinical trials will end up, and I think it's up to us to keep a close eye on the literature. And I hope now that you've got a better appreciation of how to look at the literature, not just in spine arthroplasty, but in many different types of literature that you pick up now. This is another one of my patients who ended up jumping out of the plane with a disc replacement and a parachute. Thank you.